And I'm not going to be talking about the indications for TAVI. I think you did a wonderful job with that. And I'll talk more about the current guidelines, which are now being updated for aortic valve replacement using both the US and the European guidelines. And so we have guidelines that have been available since 1998 from the ACC-AHA, updated in 2006, updated again in 2008. The 2007 European guidelines were also presented. These guidelines share something in common and unusual in terms of the cardiovascular guidelines because unlike most areas of cardiovascular medicine, we do not have an extensive database. What is the evidence-based management of aortic valve disease? The evidence base is limited by an inadequate number of randomized clinical trials, and therefore virtually all of the recommendations are based on expert consensus, level of evidence C. And therefore changes in guidelines that occur with time could represent changes in evidence, but may also represent different members of the committee who come and go and sometimes are better able to share consensus. Aortic stenosis, as we've been discussing, occurs in three forms. Rheumatic disease, which we'll be discussing in the second half of the session today. We spent extensive time yesterday talking about the bicuspid valve, congenital aortic stenosis, or calcific aortic stenosis. All three of these share a very similar common pathway that Paul Wood described very, very well in the Nathanson lecture in 1958. If you read the first sentence of his treatise, aortic stenosis is a simple mechanical fault which, if severe enough, imposes a heavy burden on the left ventricle and sooner or later overcomes it. That's stated quite well. And then we saw this figure earlier from Carlo. This is the very famous natural history study by Ross and Brownwald, 1968, of increasing obstruction, a latent period, and sooner or later, patient will develop symptoms. And then after symptoms develop, within 2 to 3 years, the majority of patients will have died. These data, first of all, there's no data. This was a concept by Ross and Brownwald based upon 45 patients. They then shared the experience of Paul Wood for his 200 patients, so they had some numbers. But this figure, which we all show, there's no data. It's a concept. And the remarkable thing is that it's accurate. And in the current era, this curve also shifts to the right. It's a biphasic distribution. The congenital patients on our left, but now we have this aging population where very similar findings occur once symptoms develop. And so this concept has been proven true for the next 40 years with real data, such as these by Bach and co-workers, following patients who were found to have severe aortic stenosis. The asymptomatic group does well, but the symptomatic group, as Carlo told us, has the mortality predicted by Ross and Brownwald, such that in 18 months, 50% of the patients have died. So for a guidelines committee, this is a very simple solution. Symptomatic patients should be a class 1. It's true for both the European and the US guidelines. Also, patients who may be asymptomatic, who have left ventricular systolic dysfunction, where the afterload mismatch has led to a low ejection fraction. Severe aortic stenosis is also deemed a class 1. But I would argue that those patients do not occur frequently. I think when a patient has a low ejection fraction, the patient probably has symptoms, and we as clinicians have not been able to tease that out of our patients. Or more likely, if your patients are like my patients, the patients have symptoms. They're deconditioned, overweight, elderly, and trying to understand what is a mild symptom sometimes is quite difficult. And that actually leads to the majority of the patients we see. What do we do with the asymptomatic patients who have truly severe aortic stenosis? The first question to ask in these patients is, are they really asymptomatic? Again, we as clinicians sometimes have difficulty obtaining accurate histories, and at least in my country, we have many patients who are short of breath because they're overweight, elderly, deconditioned, etc. And this is where exercise testing can be quite helpful, and both the US and the European guidelines have suggested that a patient who develops symptoms or has a decrease in blood pressure, abnormal blood pressure response with exercise, could also be considered a candidate for surgery because of this abnormal symptom or hemodynamic response. The level of enthusiasm differed, as you can see, between the US and the European colleagues, but the thinking is there, and I personally do perform exercise testing quite frequently in a very carefully controlled environment with a physician close by who knows the diagnosis and is able to follow the patient very, very carefully. In that setting, it is safe. Are asymptomatic patients at risk of sudden death? Should this enter into our decision making? Indeed, sudden death can occur. If we look at the natural history studies that are available to us over the course of time, 1,200 patients in the literature, 20 sudden deaths, but over a mean follow-up period of 3.7 years, less than 1% per year. The paper from Pellica and co-workers at Mayo Clinic had 600 patients, 11 sudden deaths, mean follow-up of 5 years, so again, less than 1% per year likelihood of sudden death. So it's equivalent to clearly to the risk of surgery. And so to recommend surgery to prevent sudden death in all patients, I think, would not be warranted. And so the guidelines statements are relatively evidence-based in this regard, that asymptomatic patients are at low risk of cardiac death until symptoms develop, but then a usual guideline statement follows. Should be followed frequently and carefully. Now I would ask you whether that's a helpful comment to you or not. Frequently, carefully, how frequently, how carefully? The guidelines stop at that point and don't tell us how to manage the patient. So here is a patient of mine who is 82 years old, has preserved left ventricular function, calcified valve, left ventricular hypertrophy. The Vmax is 4.6. The gradient is 52 millimeter mean gradient. The aortic valve area is less than 0.7. So this fits all of the criteria for severe aortic stenosis. What should we recommend for this asymptomatic 82-year-old man? This is a difficult decision in an older population, but we do have data regarding the natural history of patients depending upon the severity of aortic stenosis. These data from Catherine Otto show that when the Vmax is less than 3, the outcome is much different than when the Vmax shows moderate stenosis, 3 to 4 meters per second, where there's attrition. And when patients begin with a Vmax greater than 4, such as the patient we just saw, over the course of 5 years, virtually every patient develops an indication for surgery. These data are not unique. The paper from Rosenheck and co-workers had very similar findings in patients with a Vmax greater than 4. Patient followed by Pellica at Mayo Clinic, very similar findings with a Vmax greater than 4 as well. So these were not unique data from Otto. Moreover, the Rosenheck paper gave us further information, further identifiers of higher risk individuals. When patients have a rapid progression of aortic stenosis with a Vmax increasing greater than 0.3 meters per second per year, or with Rosenheck, if patients have significant calcification, such as the patient's echo we saw, higher likelihood of coming to surgery in the short term. And now in the current era, the degree of calcification could be tested with CT scans quantitatively. Aortic valve calcium scores shown in 2 studies as being independent predictors of the likelihood of requiring surgery. And then finally, Rosenheck's group came back several years later with a larger number of patients who have severe aortic stenosis with a Vmax greater than 4, demonstrating that one could further stratify patients according to the severity of aortic stenosis and likelihood of requiring surgery. And so in an older person who has a Vmax greater than 5, where there's such high likelihood of requiring surgery within 3 years, would it be wrong to at least to begin having a discussion about the likelihood of requiring surgery and perhaps a earlier intervention? Here's a patient of mine, very heavily calcified valve, followed since 2006, as you can see, up till September 2011, progressively increasing Vmax to 5.2, mean gradient to 68, aortic valve area 0.8. Totally asymptomatic individual, 69 years old, but with that trend, we replaced his valve 6 months ago, and now he's doing quite well. So this is also entered into the recommendations. When there's a high likelihood of rapid progression in an asymptomatic patient with severe aortic stenosis, it's a class 2B. Very severe aortic stenosis with a Vmax greater than 5, mean greater than 60, or aortic valve area less than 0.6, which I think we would all agree is quite severe. One might consider surgery just because the valve is so severely stenotic. And in the European guidelines, moderate to severe valve calcification and rate of progression greater than 0.3 meters per second per year was a 2A recommendation. For just a few minutes, we'll talk about aortic regurgitation, less common, but also quite important for us as clinicians. The leading causes are shown on this slide, and as we discussed yesterday, about 50% of the patients who come to surgery for aortic regurgitation have diseases of the aorta, and the leading cause for that is a congenitally bicuspid valve. As we discussed yesterday, that the valve is associated with aortic root pathology, increased degeneration of the matrix, increased expression of MMPs, metalloproteinases, decreased tissue inhibitors of metalloproteinases, and increased vascular smooth muscle cell apoptosis. So there are tissue abnormalities, and as Rio Torri showed us yesterday, there are also very severe flow abnormalities, as shown here with this 4D MRI from Dr. Michael Markle in our group, showing these high velocity jets and vortices that also create extra tissue stress on what may be underlying genetic and cellular pathology leading to the aneurysms that one can encounter. And so the guidelines from both continents say aortic valve diameter, aortic root diameter greater than 50 millimeters, or a rate of increase greater than 5 millimeters per year would be a class 1 indication for surgery in the absence of a valvular recommendation. And when patients have the criteria for aortic valve replacement based upon aortic stenosis or regurgitation criteria, one would not leave the aortic root alone if the aortic diameter was greater than 45 millimeters. These thresholds, I think, vary from center to center depending upon the expertise of the surgeons and our own experience as to how our outcomes go. And so these are not necessarily absolute numbers. Regarding the indications for surgery for aortic regurgitation, one first has to quantify severity. This appears severe from color Doppler. And indeed, one could also look at the regurgitant volume, regurgitant fraction, and effective regurgitant orifice using Doppler criteria. One should confirm that there's a volume load as well, so there should be left ventricular dilatation, confirming our suspicion that the aortic regurgitation is severe. If we do so, the preoperative predictors of survival after aortic valve replacement have been shown in numerous studies to be predicted by the ejection fraction and the left ventricular systolic size in virtually all series that have followed patients postoperatively. Found these to be important preoperative predictors, and of course these are measures that can be obtained quite accurately, reproducibly, and non-invasively with our current tools. Regarding the natural history of asymptomatic aortic regurgitation, our database, again, is somewhat limited to 1,000 patients in numerous natural history studies, but they are consistent in indicating that in asymptomatic individuals with normal ejection fractions, the rate of patients coming to surgery because of symptoms or left ventricular dysfunction or having sudden death is less than 5% per year, with an average of 4% per year. The natural history looks something like this. In a series of 104 patients we followed at the National Institutes of Health. Over the course of 10 years, 64% of patients remained asymptomatic with normal ejection fractions. Tornos and co-workers in Spain had very similar data with 101 patients. Borer and co-workers in New York, slightly higher attrition rate with very similar looking curves with 104 patients as well. These are not patients dying, these are patients predominantly coming to surgery because the endpoints are symptoms or asymptomatic left ventricular dysfunction, very few sudden deaths. And so these are predominantly identifying patients who are coming to surgery. However, one could also argue that there's an issue here in that 30% of the endpoints, that is asymptomatic left ventricular dysfunction or death, occur before the patients have a symptom. And so we need to do more than just careful history taking in these patients. And we now know from numerous studies that there are factors that predict the likelihood of progression and the likelihood of patients developing symptoms or LV systolic dysfunction. These include the systolic dimension or volume on echocardiography, and diastolic dimension or volume, ejection fractions with exercise, and then importantly, serial changes in those measurements over the course of time. So the indications for valve replacement in both the US and European guidelines: class 1 for symptoms, LV systolic dysfunction at rest, patients undergoing other forms of cardiac surgery who have significant aortic regurgitation. Where the guidelines differ is in the severity of left ventricular dilatation. A 2A recommendation from the US for severe dilatation, shown here, systolic dimension greater than 55 or diastolic diameter greater than 75. That's very severe dilatation. Whereas the European guidelines have a 2A for less severe dilatation. The same level of dilatation is also a 2B in the US guidelines. I personally I follow my patients, and as they're progressing and showing more dilatation over the course of time, I would usually recommend surgery well below those particular thresholds. And if we choose our timing well, we have very gratifying results. A patient of mine, before and after surgery, who has a severely dilated left ventricular chamber, returns 4 months after a prosthetic aortic valve with restoration of left ventricular size and function. These guidelines have not been tested prospectively, but a retrospective data set by Tornos and co-workers from Spain identified 2 patient groups who did differently following aortic valve replacement. Group A fulfilled the criteria defined by the guidelines. Group B were patients who had been followed beyond those cut points and would not have been followed according to guidelines recommendations. They were operated upon too late in natural history with a worse outcome. And so these are some data from a retrospective look suggesting that the guidelines may be helpful. So to summarize, the goal is to operate late enough in natural history to justify the risk of intervention, but early enough to prevent irreversible ventricular dysfunction, pulmonary hypertension, chronic arrhythmias, and in some patients, sudden death. The balance between the natural history versus risk of surgery clearly favors intervention in symptomatic patients and those with LV dysfunction. In asymptomatic patients, the balance is now beginning to shift toward earlier intervention, but we need to be careful if we're recommending early intervention in asymptomatic patients to be certain that the cardiologists on the equation have been accurate in the assessment that we're dealing with severe AS or AR, and then we're referring our patients to centers with established expertise in evaluation and surgical correction. And I think the experience we'll hear about in Hamad in a few minutes from Dr. Abdul Wahid will indicate the kinds of results that we've been talking about. Excellent evaluation, excellent surgical results, and this is the way to provide the best outcome for our patients. Thank you very much for your attention.
Thank you both. Congratulations. You must have been asked this question many, many times, but what is your policy with patients with small aortic valve area and depressed systolic function? So dobutamine, operate everybody. How do you do it?
Yes, so thank you, Jacopo. So it's a very common scenario now when we're dealing with patients with left ventricular dysfunction, low output, low gradient, which patients have a cardiomyopathic process with a murmur, and which patients have aortic stenosis. And you answered the question as I would have, that the current trend now is to give dobutamine either in the cath lab or echo lab to increase the flow to get a more accurate measure of the valve stenosis, and also to assess contractile reserve at the same time. The more difficult subset currently are the patients who have low flow, low gradient aortic stenosis with a normal ejection fraction, which is now quite a controversial subject as to how we identify those patients I think in the past we never considered those patients could have true aortic stenosis if the ejection fraction is normal and they have a low gradient. We now know that there's some patients there who have very small ventricles, small end systolic and diastolic volumes, and a low stroke volume, even though ejection fraction is normal, who we may be missing. And I think that's a much more difficult situation to deal with.
Thank you very much. I think in general, please tell me if you agree with me. If I am in an edge situation, I'd rather err towards an earlier replacement than a later replacement, because I may not see the patient next follow-up. My question is, with regard to sudden cardiac death, I know that deaths in symptomatic and asymptomatic severe aortic stenosis is quite dramatic. But I'm a bit surprised, I don't know if my colleagues had the same impression, of how small the numbers of sudden cardiac deaths, given also that these patients is the age where coronary artery disease, a major cause of sudden cardiac death, is there an explanation? And my last question is there a change in the indications for coronary angiography prior to surgery?
So the second question is easy. I think the indications have not changed. Clearly before surgery we need to determine which patients have associated coronary disease. Now, in a younger population, this might be done with a CT scan. So that might be a change, because we do this non-invasively now with CT. Of course, in an older population where we have aortic and coronary calcification, then I think the only way to determine the stenosis severity of the coronaries would be to do a invasive angiogram. So we do this rather routinely, preoperatively. The other issue, though, is the likelihood of sudden death. Now, clearly, I think we all have had experiences clinically and somewhat anecdotally that it occurs. When one goes to the literature and tries to identify the sudden death, it's quite difficult. There are some papers which I did not quote, which show a very high likelihood of patients dying over the course of time when they have very severe aortic stenosis and have not been operated upon. Even though initially asymptomatic. What's not clear to me in following some of those papers is whether those patients remained asymptomatic and whether the mode of death was sudden or not. So clearly I take your first point, and that is I think we tend to have a lower threshold now, and when in doubt, if the patient has severe aortic stenosis, progressive aortic stenosis, one would not necessarily wait for severe symptoms. Even early symptoms would be an indication for surgery. And I personally have recommended aortic valve replacement for asymptomatic individuals in whom the progression is rather clear-cut and dramatic.
Thank you, Bob, for your presentation. I have two questions. One is the old ladies with a tiny aortic root, 1.9 or even lower, the choice of a valve substitute and the importance of a residual gradient, particularly if the ventricle appears to be impaired. And Heidi Connolly showed that the residual gradients correlate with high perioperative mortality, but then they do much better later. In these patients, the use of an unstented aortic root 2.5 or 2.3 in a 1.9 root seems to be a very good solution. I want to know your views about that. My other question is the presence of severe left ventricular hypertrophy with or without fibrosis. We know that these are very poor prognostic indicators in hypertension. Why are we ignoring them in aortic stenosis?
Yeah, well, I'm not sure we do, although it doesn't creep into the guidelines, or actually, as you know, was in the guidelines and then came out in a second edition of the guidelines 10 years later regarding the hypertrophy. I think we all follow patients, and as the ventricles become thicker and stiffer, that's certainly something I would use clinically to recommend surgery.
Even if they are asymptomatic?
Even
if they are asymptomatic?
Not necessarily, but I think we're talking about the same person, actually, which would be an older woman who's likely to have a smaller diameter annulus and also a lot of hypertrophy. Most of the studies have shown that there's a gender difference in the response to the pressure overload. Women tend to have a more hypertrophic response. They begin with smaller ventricles, and now they have a truly small ventricular cavity. And these can be problematic patients perioperatively, as you know, very volume sensitive. And this, I think, would explain why those patients need to have a operation which leads to less residual stenosis. And I would agree with you that a procedure to remove the stenosis and leave the patient with less residual stenosis is important. But I will need to ask you in return how the surgeons would deal with that. Would they want to put in a stentless valve? Would they want to do a annulus enlarging procedure of any kind? And I think I've heard different responses from many different surgeons over the course of time.
Simple aortic root replacement with an unstented valve, and you
Right.
something like a Medtronic freestyle with massive oversizing,
Mm-hmm. Yes.
2.5 in a 1.9 root.
And you do a myectomy as well.
If there is evidence of subvalvular hypertrophy, but I used to do that a lot more often than now.
I think we should move on, and maybe Dr. Of course, although
an aortic incompetence, let's say the guidelines are clear, but then I mean, let's say in symptomatic patients that's clear, but in asymptomatic patients, the watchful let's say you wait and watch the patient, and then when develops the criteria for intervention, then you intervene. Is that directly related to the mortality? Let's say the mortality may be similar whether you operate or not, or related to, let's say, the morbidity associated with the valve replacement, the long-term morbidity associated with valve replacement. Having said this, the advocates of valve repair, for example, in aortic incompetence, would say that you should intervene earlier because at this an expert hand aortic valve repair has got a good long-term result.
yeah.
Would that be an option?
So you're raising some of the delicate points we deal with on an individual basis. There's two groups of patients with aortic regurgitation. The older group, which the Mayo Clinic has reported on, where there's actually a higher likelihood of death even before surgery. But in my experience, many patients I see with aortic regurgitation that's severe are young people with bicuspid valves, where you don't want to wait too long, and at the same time there's no perfect solution if we're going to replace the valve in a young person, especially a woman. And this is where aortic valve repair becomes very attractive, or perhaps a Ross operation becomes attractive. And this is where one has to choose the patient well, choose the surgeon very, very well as well, in addition, someone who's expert in repairing valves. There's growing experience in some centers with aortic valve repair. I'm interested perhaps in hearing your experience as well, but I know that many patients who are possible candidates for repair, when in the operating room, leave with either a valve replacement because the valve is not repairable, or the valve repair is performed but it's not a long-lasting situation, as it is with mitral valve repair. So I'm still troubled by the correct management for these young people who've got very severe aortic regurgitation. And I will admit that I individualize, and I've had some patients go for Ross procedures, other patients go for valve repairs, and others who wind up getting a valve replacement with a standard mechanical or bioprosthetic valve.
Would you recommend that early intervention if the valve is repairable?
I would agree entirely on individualizing just how repairable is repair, and accepting anything less than optimal is a problem. So it needs a lot of thinking before subjecting the patient. Certainly if there is one prolapsing cusp, but you can see there's a lot of cusp tissue and the good quality tissue, without leaving areas very thick, roughy. And we know that just prevents the movement. And now we can also quantify, like you have shown, the amount of calcification and localize it in different parts of the valve. If the hinge mechanism is affected, how thick is the raphe, and how distorted is the aortic root. But if everything is ideal, for sure, go for it early.
Yes, and I think it's also if it's a root problem, where one can do a valve sparing aortic root replacement, that may also lead to a valve that now functions much better and perhaps with less regurgitation. Am I correct?
Yeah, I think with the root replacement, that you have an indication on its own now, because you're out of the, you're in a different area, if you like.
Okay.